Hello, everyone. Welcome back to Neurospicy Nursing. Today, we're going to go over some pediatric GI disorders, or disorders that you would be diagnosed with during that pediatric period. So yeah, let's get on into it. So this is a little photo that I drew of the GI tract. So just, it's not the best, so just bear with me. Also, I've got awful handwriting if you guys can't tell. But I really did try my best. All right, so basics of the GI tract. Remember that our upper GI is going to handle the intake. It's going to be, the mouth, the esophagus, and the stomach. The lower GI is going to handle the digestion and absorption and elimination, also metabolism. So, like when we're thinking of medications and the pharmacokinetics of medications, that's no normally your lower GI tract. Um, our small intestine is going to absorb carbs, fats, proteins, minerals, and vitamins. Large intestines focuses on water balance and stool formation. The liver is going to help metabolize nutrients and detoxify drugs. As we all know, the kidneys can also do that, but for GI tract specifics, the liver does that. Our gallbladder is going to store our bile for fat digestion, and our pancreas is going to produce digestive enzymes plus insulin and glucagon. All right, so developmental GI differences. You may be like, what does that mean? In infants, everything is pretty immature, so it's going to change how they eat, digest, and absorb nutrients. Their soft palate is going to be different, and their tongue position kind of helps them breathe and suck in at the same time. Their stomach is also going to empty 2.5 hours to every 3 hours, so they're going to need more frequent feeding. Digestive enzymes aren't going to start reaching a normal level until they're about 4 months old, which is why we end up delaying solids. That and because, they don't have teeth, so they can't chew. Um, Also, they have irregular peristalsis, which means that their absorption is pretty much unpredictable. And our liver and our pancreas aren't fully mature. I mean, it makes sense. Our liver isn't fully mature. That's why we give the vitamin K shot when they're first born because of that immature liver. And it doesn't end up maturing until about 6 months of age. Lipase in itself isn't going to be at an adequate level until about a year. So infants really don't absorb fats well, especially like fats from like cow's milk or any non-breast milk or formula feed. Um, and so that really helps explain why they have such interesting feeding patterns and stool characteristics. Now, our segue into feeding and digestion. Newborns should have bowel sounds within hours of them being born, right? Unless, they pass that meconium in the womb, then they'll have bowel sounds even sooner, but within hours of birth is pretty normal. Breastfed babies tend to have more watery stools when formula-fed babies have what we call seedy stools. Straining during stooling is pretty regular for infants just because it's that immature muscle coordination that they have. They're also going to need way higher caloric needs than a normal adult. So infants need about 108 calories per kilogram. Toddlers are going to need 102 calories per kilogram. And toddlers are naturally going to be picky eaters because their growth starts to slow down and their appetite is going to decrease. And then by the ages of 4 to 5, the GI tract is now mature enough to handle the full range of foods. It's also why we start to slowly introduce foods is one, we don't know if their system can handle it, and two, allergies is a big thing during this time too. So by slowly introducing it, we can figure out what foods that they are potentially allergic to. So cleft lip and cleft palate. So a cleft lip is a split in the upper lip. A cleft palate is an opening on the roof of the mouth. A baby can have one or both. So they can either have a cleft lip, a cleft palate, or they can have both of them. Both conditions are going to cause feeding difficulties because they can't form a good seal, and then they have a poor suck. A cleft palate is going to increase the risk of otitis media because that opening is going to affect the oropharynx, and then they can have milk that ends up kind of backflowing into that uh, otitis media area. Risk factors for those are going to include a maternal age over 35. Certain ethnic groups also have an increased risk of a cleft lip or cleft palate. Cleft lip is going to be more common in Native Americans and Alaska Natives. Cleft lip is usually going to be repaired around 3 months of age. Cleft palate is repaired later in life, but it needs to be before they start to develop a speech pattern. Nursing care is going to be assessing the airway and the sucking ability. There are going to be feeding modifications that also need to happen. If they have a cleft palate issue, they need a shorter nipple that directs the formula feed upwards. Or sorry, not upwards, forwards instead of upwards, so not towards the roof of their mouth, but kind of towards the back of their throat, if that makes sense. If they have a cleft lip, they need a longer nipple because they need it again further back into their throat so that it doesn't end up kind of spewing out through that lip opening. And then for risk reduction of the cleft lip and cleft palate, we are going to avoid medications like seizure meds or like methotrexate. We're going to avoid alcohol. We're going to avoid smoking. We have to take prenatal vitamins for the folic acid, and they need to have, specifically with the folic acid, those prenatal vitamins should have at least 400 micrograms of folic acid in them. All right, so the next one is pyloric stenosis. It is pretty much a very classic kind of pediatric GI emergency. The hallmark sign for pyloric stenosis is going to be projectile vomiting immediately after feeding. So they're going to eat and then just immediately projectile vomit. Um, these infants are normally going to be hungry right after vomiting because it's just kind of an endless cycle. They eat, they vomit, and they're still hungry because, their stomach's empty. Uh, you may also end up seeing like FTT. We talked about it in the pediatric emergency or maybe the psychosocial lecture. So if you don't know what FTT is, make sure that you go look at that. But FTT is something that you may see with pyloric stenosis or overall just weight loss, dehydration, constipation. They also may have like an olive kind of shaped mass that's palpable in their abdomen. And then we're going to diagnose it using an ultrasound. The treatment is something called a pyloromyotomy. And then post-op, they still may have vomiting for up to 36 hours, but feedings are going to start pretty early on. So we're going to try to start feeding them within 6 hours after surgery and then advancing it slowly. And we're going to start them with Pedialyte and then transition them into formula as they can tolerate, right? So you don't want to do it too fast. And if the infant vomits, you're going to hold the feeding at whatever current level they're at. So if they're at like, I don't know, 10 mLs, you're going to hold them at 10 mLs until they can tolerate that feeding for 2 feedings. And they need to tolerate 10 mLs 2 times kind of back to back before we can start increasing their intake again. Intussuception. I call this, for some reason, the inception of the bowel. It's just something that has helped me remember it. But it is a telescoping bowel. You can also see and let me back up. What I mean by a telescoping bowel is a piece of the bowel that goes into itself. It's usually at a specific valve, but a piece of the bowel is going inside of itself and it's causing a blockage. It is a type of intestinal obstruction, and it's usually going to occur between 6 to 36 months of age. Normally, it doesn't happen after that. But some of the classic signs and symptoms are that red currant jelly stool, paroxysmal abdominal pain, and you may see infants pull their legs up towards their abdomen, like they kind of get into like a fetal position. You can also have vomiting, distension, lethargy, and then a sausage-shaped mass that's going to be referred to as Dance's sign. What we tend to do for intussusception is going to be a barium air enema. So they're pushing air into the intestinal tract to kind of prevent or release that telescoping. And that's going to reduce the obstruction. And there's normally success up to 90% in that. Obviously, if they start getting the symptoms again, then that normally means that the enema wasn't successful. All right, so malrotation. Malrotation with the volvulus is a serious obstructive disorder. So if we go back, it's kind of a more common obstructive disorder. We see it pretty often, pretty easy to take care of, really high success rate with the enema. This one is much, much more intense, okay? So the obstruction here can lead to ischemia of the bowel, and then necrosis. And that necrosis, if it's bad enough, can actually lead to death. And it's going to happen way sooner. So this is something that happens within the first month of life versus intussusception happens a little bit later on. One of the key signs is going to be green vomit or vomit that's bilious, or basically you're just vomiting up bile. They'll have abdominal distension, abdominal pain. They can have really bloody stools, and the bloody stools, all of the signs and symptoms can indicate that ischemia, and it is a surgical emergency. Our pre-op care is going to be NG decompression, IV fluids, and then they'll have antibiotics, especially because if, let's say they have it in an area and it causes all this stool pressure and stool backup, there is a possibility that all that extra stool puts too much pressure on the intestines and boom, you get a rupture. So the antibiotics just kind of help. Plus, just the surgery in general is kind of prophylactic as well, especially because we're going into opening through a sterile area into a non-sterile area. Hopefully that makes sense. And then post-op care, we're making sure that we slow down that diet, as in slowly introduce things like ml or cc or however much we introduce it by, kind of like if you guys remember how we talked about the pyloric stenosis one, how we advanced the food slowly, very, very similar. Fluid balance, I think I mentioned, pain control, and then we're going to monitor for signs and symptom of infection. All right, lactose intolerance. I feel like most people have lactose intolerance. It's not super uncommon, but it's caused by a lactase deficiency. You can see bloating, cramping, abdominal pain, flatulence, and diarrhea all within about 30 minutes of consuming lactose. Infants can end up showing vomiting and distension or severe watery diarrhea after having a formula that contains lactose. And then diagnosis is all based on their symptom improvement when lactose is removed from their diet, and then if there's a recurrence when lactose is introduced. They also can use a hydrogen breath test to diagnose it. And then again, management, we're going to give them lactose-free products or lactase supplements. And then just choosing foods that are naturally lower in lactose, like certain yogurts and cheeses, are all going to be helpful moving forward. Celiac disease. So celiac disease is an autoimmune reaction to gluten. So it's lifelong. They don't just have it and outgrow it, okay? It's a lifelong autoimmune reaction to gluten. It's going to cause atrophy of the small intestines, and it's going to appear once gluten is introduced, which is normally about 6 months to 2 years of age. Again, you may see symptoms of FTT, diarrhea, staturia. So staturia is that really greasy, pale looking stool, bloating, abdominal pain. They also may end up with anemia, bruising, delayed puberty. They can have some dental issues. Diagnosis for them is going to require a biopsy before gluten is removed from the diet, plus an antibody testing. They'll need management for lifelong gluten-free diets. They need to eliminate wheat, rye, barley, and oats. And then there are so many, as someone who has a gluten-free diet, not related to celiac disease, but I am gluten-free. Listen, gluten is in everything. Let me tell you. It is in candy. It is in stuff that even if you think it's labeled gluten-free, there are some things it's still in, or things that you would think are gluten-free, like Rice Krispie treats have them. Airheads Extremes have them. Some soups have them as a base, right? Because if you're using a roux, that uses flour. Certain ice creams, hot dogs, lunch meats, there's a plethora of things that you wouldn't expect there to be gluten in that actually do have gluten. Anything that could contain like malt will have gluten in it. Obviously, like the standard things, anything that's wheat related, like cakes, cookies, breads, but Rice Krispie treats, certain cereals have it. Candy has it, like Twizzlers. Certain gummies have it. So making the parents aware that, like, hey, just because it doesn't specifically say that there's no wheat in it, make sure that they're reading the label because there are sneaky little things like malt flavoring and stuff like that that do contain gluten that can make their child very sick. All right, those are the resources, and that's all I have for you guys. We're going to be going over some other things this week, like immunity as well as the respiratory um, system. Respiratory is going to take a little bit of a long time because it's going to include like croup and stuff like that, and there's different subsections, but make sure you look out for that video. And that's all I have for you guys today. Thank you so much and have a great day. Bye.